I'm very pleased to be providing this December 2022 update on COVID-19 therapeutics. Here are my disclosures. Today I'm going to cover three topics. I'm going to give a rapid update on several talks presented on treatment of COVID-19 at ID Week 2022 back in October in Washington, D.C., and then provide updates on remdesivir and molnupiravir based on new clinical trials data. So the first study I'm going to talk about is Active 6. This was presented by McCarthy on behalf of the Active 6 team. Active 6 was a decentralized, double-blind, randomized, placebo-controlled platform trial of several repurposed drugs for the treatment of mild to moderate COVID-19. This study had some very unique features. First of all, it was direct to participant. The study was advertised to participants, not through their healthcare providers. And participants who volunteered to be part of the trial were then assigned to a specific site near where they lived. They conducted daily symptom reporting and COVID-19 outcome reporting. There were also remote visits, so they didn't necessarily have to go to a clinical center to be assessed. There were continuous safety assessments, and to date, there have been 5 active arms. The 3 arms whose results were presented at ID Week included ivermectin, fluticasone, and fluvoxamine, all repurposed drugs chosen by an independent committee based on existing evidence, including some preliminary human trials data. And then these studies all had a control arm. This slide shows the primary endpoint, which was time to sustained recovery. And what you can see is that whether ivermectin, fluticasone, or fluvoxamine were administered compared to placebo, there was no difference in time to recovery for any of these interventions. You see the hazard ratios below the graphs are all very close to 1, and the p-values, in this case, these are posterior probabilities because these studies were analyzed by Bayesian statistics, show that there is a low certainty of there being a difference between the arms. You'd have to have a p-value of 0.95 or greater to be statistically significant in this particular case. And for all 3 arms, the median time to recovery was between 11 and 12 days. A secondary endpoint was time spent unwell. And here there is a little bit of a divergence. If we look first at the fluvoxamine and fluticasone results, you can see that the vertical line, which is the median time to, or the mean time to spent unwell, is close to 0 in terms of the difference between the arms. And the posterior probabilities are low, 0.7 and 0.6. Curiously, for the ivermectin arm, there's actually about a half a day shorter time of feeling unwell in the people who received ivermectin, and that was statistically significant with a posterior probability of 0.99. But a half a day difference is not really a clinically significant difference. The ivermectin study has also been published now by Susanna Nagy and colleagues on behalf of Active 6, and these are data from the JAMA article that appeared at about the same time as ID Week was held. And here are 3 different endpoints. This is all ivermectin versus placebo control. And you can see that for days to sustained recovery, the results slightly favor ivermectin, but are not statistically significant because the shaded area, which represents the, in this case, the credible interval, it doesn't overlaps 1. Likewise, days to hospitalization, emergency department visits, and the like slightly favor ivermectin, but not statistically significant. And in C, we see once again the time spent unwell, and here it shows you the half a day less of feeling unwell, which is statistically significant, but not clinically meaningful. The second study presented at ID Week was really a novel intervention of a drug known as Sabizabulin, which is an oral drug, and this was administered to hospitalized adults with COVID-19 on supplemental oxygen. And this study was presented by Paula Scarda from St. Paul, Minnesota. Sabizabulin is a microtubule disruptor that has both antiviral activity and is purported to have anti-inflammatory activity as well. So it may improve outcomes in COVID-19 through two mechanisms: inhibiting SARS-CoV-2 replication and moderating the cytokine storm that accompanies severe COVID-19. Results of a previous phase 3 trial were as follows. There was a randomized, multi-center, placebo-controlled trial conducted in hospitalized patients with moderate to severe COVID-19 who were at high risk for developing acute respiratory distress syndrome or dying. And they were randomized 2-to-1 to receive either oral sabizabulin or placebo plus standard of care. And they were followed up for 21 days or the time of discharge from hospital. In a planned interim analysis, the intervention resulted in about a 55% reduction in mortality. That's a relative reduction compared to at day 60 compared to placebo. An analysis of the full data set of all 204 participants was consistent with the interim efficacy analysis, with about a 52% relative reduction in death at day 60. In the current trial, a smaller study, 88 participants who were classified as WHO, so they had oxygen requirement with a baseline comorbidity, underwent randomization, again 2-to-1 to sabizabulin or placebo. They also had to have at least one comorbidity, as you see listed there. The primary endpoint, once again, was all-cause mortality up to day 60, with key secondary endpoints including length of hospital stay, number of days in ICU, and number of days on mechanical ventilation. This slide shows the primary endpoint. I'll just note that the scale here goes from 0 to 30%, so the difference is somewhat expanded because of the way the graph is constructed. So there was a 22.5% absolute reduction in the proportion of participants dying in the sabizabulin arm compared to placebo, which represents about an 80% relative reduction. Remember, the previous trial, it was a 50% relative reduction. Here, it's an 80% relative reduction, and that was statistically significant with an odds ratio of 6.2 favoring sabizabulin over placebo, which was highly statistically significant. So conclusions from this study were that sabizabulin, a dual antiviral anti-inflammatory agent, significantly reduced deaths in hospitalized patients with moderate to severe COVID-19 who had at least one comorbidity. It showed statistically significant reductions in key secondary endpoints, which I haven't shown you, but included days in hospital, days in the ICU, and days on mechanical ventilation as compared to placebo. Participants with sabizabulin experienced fewer adverse events and fewer serious adverse events as compared to placebo. And the analysis suggests that antiviral and anti-inflammatory actions contribute early in the prevention of COVID-19 progression to ARDS and death. This drug has been submitted for consideration for emergency use authorization, but that is still under review. And then a third study, also part of the active collaboration, this one Active-1, the immune modulatory component of Active-1, presented results on the administration of abatacept or infliximab on mortality in patients with COVID-19 pneumonia. This was presented by Emily Coe from the Duke Health System on behalf of the Active-1 team. So an overview of the protocol: the study objectives were to evaluate multiple immunomodulatory agents for the treatment of moderate to severe COVID-19, assessing each agent compared to a shared placebo as an add-on to the local standard of care in accordance with national guidelines. So in this case, because of the timing at which the study was done, remdesivir had already been approved and was provided. There were 3 different agents studied: infliximab, which is a TNF-alpha inhibitor, given as a single infusion at 5 milligrams per kilo; abatacept, a co-stimulatory modulator, given as a single dose of 10 milligrams per kilo IV; or cenicriviroc, which, for those of you familiar with HIV drug development, is a CCR2, CCR5 dual inhibitor. It's also been studied for its CCR2 antagonist properties as a potential antifibrotic agent in people with non-alcoholic hepatic steatosis. These participants received an initial loading dose and then 300 milligrams daily for 28 days. That arm of the study was discontinued back in September of 2021 for futility because there was no demonstrable benefit. So the primary and secondary endpoints of the study were, first of all, time to recovery, and the recovery rate ratio and associated confidence intervals were analyzed, stratified by region and severity and by various covariants. There were two key secondary endpoints, day 14 clinical status on this now very familiar 8-point ordinal scale, and 28-day all-cause mortality. And data analysis was conducted as a modified intent to treat population basis. So these are the results for the infliximab arm of the study. The primary endpoint, or time to recovery, failed to meet statistical significance, but there was a trend towards improvement. You see that at day 28, there was actually a statistically significant improvement, but that improvement did not persist out at day 60. Likewise, with abatacept, the primary endpoint of time to recovery was not statistically significant. And again, there was a trend towards improvement with abatacept, with about a 38% lower odds of dying by day 28, which once again was statistically significant, but with longer follow-up, mortality in the abatacept arm caught up, and there was no longer any statistically significant difference. So conclusions for active 1 IM, the investigators found substantial benefit 28 days in terms of a reduction of all-cause mortality for both infliximab and abatacept, but these findings did not persist to 60 days. The findings showed similar results compared to other immunomodulators such as baricitinib and tocilizumab, each of which demonstrated about a 4% absolute reduction in 28-day mortality when added to standard of care. The subgroup analyses demonstrated benefit of participants on low-flow oxygen, that is, those with moderate disease, and enrichment of the mortality benefit was found in participants with particularly elevated C-reactive protein levels. Well, let's turn now to an update on data regarding remdesivir. The Solidarity study, which was organized by the World Health Organization, was a randomized platform trial that compared several different drugs, including remdesivir, lopinavir, hydroxychloroquine, and interferon beta 1A to standard of care. Adult patients recently hospitalized for confirmed COVID-19 were eligible for enrollment with a primary endpoint of in-hospital mortality and secondary endpoints that included progression to ventilation, time to hospital discharge. And in these data presented here, which were published in Lancet a couple of months ago, nearly 8,300 patients were randomized equally between remdesivir or the standard of care arm. This slide shows the outcomes based on entry status of the participants. So first of all, if we look at panel D in the lower right-hand corner, you can see that overall, there was no statistically significant benefit of remdesivir. The rate ratio was 0.9, and the log-rank p-value failed to reach significance. And you can see there's about a 1% absolute difference in the rate of mortality. However, if you parse out the participants based on their clinical status at study entry, starting with panel A in the upper left, there's no difference for those who were not sick enough to require supplemental oxygen. Similar to previous trials, for those who were on low flow or high flow oxygen but not yet ventilated, there was a difference. It's a modest absolute difference, only about 1.7% difference, but that is about a 15% reduction in terms of the rate ratio, which was statistically significant with a log-rank p-value of 0.03. For those already ventilated, there was no statistically significant difference, as you can see in the lower left in panel C. Looking at the secondary endpoint of progression to ventilation, there was a significant benefit of remdesivir, although modest, about a 12 to 15% benefit in reducing the risk of progression to ventilation for those already on oxygen but not yet ventilated. There was a similar modest 13% or 14% reduction in progression to death for those already on oxygen but not yet ventilated. And if you combine those two endpoints and looked at death or progression to ventilation, there was about a 15 to 16% reduction in risk for those who received remdesivir. So these results support the use of remdesivir in hospitalized patients who require supplemental oxygen. Lastly, I'll cover an update on molnupiravir. Molnupiravir is another RNA polymerase inhibitor, that inhibits SARS-CoV-2. It is believed to do so through accumulation of mutations. This was a UK-based, the PANORAMIC study was a UK-based open-label adaptive platform trial in symptomatic outpatients with confirmed COVID-19. Nearly 26,000 participants were randomized one-to-one to receive molnupiravir plus standard of care versus the standard of care alone. Because these were outpatients, standard of care principally involved symptomatic treatment. They weren't getting other antiviral therapy, and very few of them were getting corticosteroid therapy because they didn't qualify. They didn't need supplemental oxygen. The primary outcome was a 28-day all-cause hospitalization or death, and the secondary outcome was time to self-reported recovery. Just a little bit about the baseline characteristics. The median age of the participants was 57 years. Virtually all of the participants had been vaccinated against SARS-CoV-2. 24% were using inhaled steroids for various reasons, but they were not getting oral dexamethasone. And you can see in the bottom, although the font is a little bit small, I apologize. The primary endpoint here was equal in the molnupiravir and usual care groups. 0.8% of participants in each group experienced hospitalization or death within 28 days of study entry, which led to an estimated treatment effect of 1.06. And you see the credible intervals here overlap 1, so this is not statistically significant. These are again Bayesian statistics, and so the posterior probability of there being a difference is extremely low, with a p-value of only 0.34. However, if you look at time to self-reported recovery, there was a difference, and this was statistically significant. And you can see in this Kaplan-Meier plot that the median time to recovery for the molnupiravir group was somewhere around 9 days or so, and it looks like it was around 14 days or so for those who received usual care. So although there was no difference in disease progression, there was a more rapid recovery. Whether that makes molnupiravir an appropriate intervention in those people who are not able to receive nirmatrelvir, ritonavir is an issue that needs to be debated, and perhaps something we can get to during the question and answer period. So that's my last slide, and thank you very much for your attention. I look forward to our question and answer period.